So for today, thank you for joining us for the Embedding the Caregiver Experience in Your Ontario Health Team webinar. We've gone over a little bit of the housekeeping, but as everyone continues to log in or tries to navigate where the chat is, please use the chat to introduce yourself. We will have points throughout the webinar where we have questions and open to having you ask questions throughout there, share your thoughts as our panelists go through the presentation. If there are any issues in particular, for example, you can't hear us or the screen has gone blank, do try to raise your hand if you need any customized support. If there's a larger issue, feel free to go within the larger chat. And then finally, to connect and bridge the network within the webinar, please feel free to also share your handle in the chat for those to follow you on Twitter, and of course to give the Change Foundation a follow on our social media platform as well. And as for the land acknowledgement, we acknowledge the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and the Wendat people, is now home to many diverse First Nations, Inuit, and Métis peoples. We acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. We also acknowledge that Canada is home to many diverse First Nations, Inuit, and Métis people, and that each of you are joining us from one of those many traditional and treaty territories. We're grateful that we are able to come together in this way today. And for today's presentation, a quick introduction to our speakers. We have Kathy Fuchs, the President and CEO of the Change Foundation, Krista Hanshaw, the Executive Lead of Strategic Communications and Young Care Portfolio, as well as Harpreet Bassi, the Executive Lead of Program Implementation. And in terms of the agenda, you'll be able to follow along based on the speakers, but also from a visual cue as we go throughout the deck, just to see where we are at the top right icon. So we'll just about to wrap up our welcome, then we'll be moving into, with Kathy, a little bit about the Change Foundation. Krista will dive into understanding the caregiver experience. Harpreet will share many of the co-designed tools and resources by the Change Foundation and our changing care teams. And then we will shift into an open discussion with you, all of you on the line through the chat to the Ontario Health Teams, and then finally wrap up by 11:30 with closing remarks. And with that, I will turn it over to Kathy.
Thank you very much, Jocelyn, and good morning, everyone. Let me add my welcome to all of you. Thank you for taking some time out of what I'm sure is a busy day to spend with us. But in particular, I want to thank the caregivers that have joined us this morning. I hope you find this a rewarding experience. So my job is to talk a little bit about the Change Foundation. And the reason we're doing this is partly because it's an organization that I love, and I take every opportunity I can to talk about it. But more importantly, the work that we've been doing in the last 8 years, I think is quite germane to the work that many of you will be doing in developing your OHT applications, or even if you're not in an OHT environment. I think all communities in the province are trying to think about how they can better integrate care locally so that patients and caregivers and health providers as well have a better, more fulfilling experience in their work life or as they are accessing care. So we were established in 1995. We're about to celebrate our 25th anniversary. And we were originally set up by the Ontario Hospital Association as a charitable endowment with a very broad mandate to focus on Ontario health system change. At the moment, we're focusing on patients, caregivers, and staff, and we will get into that in a little bit more detail in a minute. But we've actually evolved over the 25 years many times as we have read the environment and tried to figure out how this jewel of a foundation can contribute to health system reform. How do we do that? We start by listening. So everything we do is predicated on deep engagement with various parts of the system and with people who use the system to try to figure out what we could do better. We learn from those conversations, and then we design funding processes in order to support people who want to engage with us on a journey of change, and we learn from that and evolve again. We have 4 very large buckets of activity by which we learn, act, evolve, and then listen again. We do research and evaluation, although I would say it's not the kind of academic research that you might think of when you see the word research. We're not particularly focused on sort of journal articles and publications, although that does happen sometimes. But we are very focused on evaluation so that we understand at many levels the projects that we fund, the teams that we work with, and the foundation itself. Are we doing what we set out to do? Are we being effective? And are we moving the yardstick in terms of change? We do a lot of policy analysis because obviously we work in a health system which is largely publicly funded and has quite a lot of government support. So we want to understand whether the policies that are in place are actually helping, and if not, how can they be improved? We focus very much on the delivery system. We understand that change actually happens at the coalface where care is being provided, and so we want to look quite granularly at what happens at that point of interaction and whether or not that delivery system can be improved. And when we do that, we always do it under a philosophy of co-design. So we always have users and families working alongside people who are delivering services. And as I said earlier, we do deep engagement. We come from a place of a logic model, so the details on this are frankly quite irrelevant, but the point is we want you to understand that we spend a lot of time thinking about if we're going to invest, how we invest, what we have to give in terms of money and people, and the people that we work with, what we can produce ourselves or what we can produce through others, such as the research, the policy, the redesign expertise, and the engagement protocols. And then we try to hypothesize on the short term and the longer term, if the things we do work, what would we expect to happen? And that's where we then evaluate our own impact as a foundation. So we started this work almost 8 years ago now, almost 9 years ago now, where we were very focused on patient experience. Way back in 2010, it was not something that was high on the agenda. It was there were people talking about it, but it was not seen to be a primary lever for change. And so we spent quite a lot of time trying to think about, well, what could we do as a foundation to work on that? And we had 2 very significant pieces of work. One was our Panorama panel, which was 35 patients and some caregivers, one of the first to actually be convened in the province, that worked quite closely with the foundation in terms of designing what we would end up spending money on. And then we funded a large team in the Northumberland area called PATH, which was a group of organizations and a group of patients who were trying to improve specifically the transition home from hospital to home. But during that process, we kept hearing, particularly from patients, quite a high level of frustration about how their family members were not really being engaged in their care. There was all kinds of expectations about what families could do, particularly when somebody was going back home. And even though we heard a lot about it, we didn't address it because we were so focused on the singular patient experience, and we, in a way, replicated the mistake of not understanding that caregivers were really part of a patient experience. So when we had an opportunity to design a new strategy in 2015, we pivoted quite strongly to focus entirely on family caregivers. And I don't think it's inconsequential that many of us at the foundation, both at the board level and at the staff level, were caregiving as well. So it was something that we saw professionally, but something that we felt quite deeply personally. So we set out to listen. We started with our listen box, and we spent a year engaging quite deeply with hundreds of caregivers and hundreds of providers. We did this in a partnership with the Ontario Caregiver Coalition because they're deeply engaged at local level with caregivers, so that we could really understand if we were going to do something, where should we be focusing our attention? And we heard 4 strong themes. The first was communication, that caregivers and staff actually needed better communication and exchange between caregivers and healthcare providers because the caregiver actually was usually more knowledgeable about the patient than anybody else. There was an issue around assessment. Caregivers wanted to be understood, and they wanted people to, they didn't want to be assessed per se, in terms of what you might think of with that word, but what they wanted was somebody to ask them how they were doing. They wanted recognition that the role itself was important and that they had a lot to bring to a healthcare discussion, both about patients but also about system-level barriers. And they needed support. They needed some education to develop their skills that were going to be expected of them in terms of how they were to care for somebody. And in some cases, they needed counseling for themselves. So the CARE ended up being called Changing Care. And this is our big investment in a number of organizations across the province. Here's where they are. We have 4 partnerships that we're actually supporting right now. We're in the last year of a 3-year funding agreement with those organizations, and they have been co-designing all the way along what could be done locally to improve both the caregiver, but also the staff experience. This is where they're located, and the only reason, frankly, we're putting these up here is because the organization of these teams is not dissimilar to an OHT. So these are groups of organizations in a community, healthcare providers, who have come together collaboratively with a shared purpose to improve the caregiver and staff experience. Everything they do is co-designed with caregivers, and there are many, many solutions that have come out of this collaboration, which you're going to hear about later, that may be of use to you as you're thinking about health teams. The other thing that we've learned about, and again, I think this is significant, is what do you do when all of these organizations have their own governance structures? How do you create partnership? How do you create collaborative learning and collaborative governance? How do you share resources, which is both money and people? So we think there are some really strong lessons here from a group of organizations and people who've been in the trenches for 3 years before health teams ever became a thing, that we all have a lot to learn from. So that's the reason we're putting that up there. And I think it's not a coincidence that a number 2 of the 4 and one of the partners in one of the other 2 are all in phase 1 health teams. So now I'm going to turn it over to Krista, who's going to take you through what we have in terms of data and understanding the life of caregivers in Ontario.
Thanks so much, Kathy. And I want to just extend my welcome to everyone on the call as well and on the webinar. It's really interesting to see the mix of people here from all parts of the system, and also a number of caregivers. And so it's really, I think, an indication of how the province is working together and the teams are working together and with the full spectrum of stakeholders around the table. So thanks for joining us. As Kathy said, I'm going to talk about the Spotlight data that we did in 2018, our first survey. And really, we know there's a lot of information about caregivers and particularly around caregiver distress, but what we wanted to do was look more deeply at the experience of caregivers in the healthcare system particularly. So just to remind everyone, there are 3.3 million caregivers in Ontario. That's 29% of the population. And I'm going to walk you through some slides today that dig a little deeper into who exactly those caregivers are and what they're doing. So we know that there's sort of an equal split of caregivers between male and female, but we also know that we see a lot more women coming forward as part of our engagement efforts, and that women and men sometimes need different types of supports or have different needs. So it's an interesting number to look at because there actually are equal, but we often see a lot more women reaching out for support. Caregivers come in all ages, and I think we often have sort of a typical picture of caregivers being maybe an older caregiver to a spouse or an aging parent, but I want to point out the 17% being young carers between the ages of 15 and 24. So that's 500,000 young people in Ontario who are caregivers in that age group. And we know from our deep work in the area of young carers that there are many, many more under the age of 15 who are not captured in those statistics. So just a reminder to those thinking about caregivers that there are youth caregivers who have distinct needs. And then we also know that there are many who are married in common law relationships. There are about 27% who are single or never married. And then there's the sandwich generation group, which we know also has very distinct needs. And again, I'm going to dig a bit deeper into that. So although each caregiver experience is definitely unique, and we hear that again and again, there were some themes that came out in this survey that are worth highlighting. First and foremost, caregivers do not self-identify as caregivers, and that is a really big problem because even the term caregiver is sometimes something people don't relate to. We know that the self-identification issue is even larger in young carers, so 71% of young carers would not self-identify. Family caregivers hesitate to admit they're struggling. I'm going to talk a little bit about that later. At a very top level, if you say, how are you doing? They'll say they're fine. But as you'll see in the data in a minute, they're actually struggling. And we know that caregiver experiences are influenced by where they live, who they care for, their other life responsibilities, and the intensity or length of their caregiving experience. And part of what we want to cover today is how those factors, geography and the social demographics, influence how people see and feel about their caregiving. I think I want to underscore this really key point as the last point on this slide is that family caregivers do not believe that their family member would get the same level of care or attention if they weren't there. And that really adds to the stress and the responsibility that they feel in caring for their loved one. So we know that caregivers are doing a whole bunch of things, from emotional support to transportation to grocery shopping to work around the house, both inside and outside. But we also know that they're providing basic medical tasks and that 21% are actually providing true medical procedures at home. And so we need to think really deeply about caregivers as members of the healthcare team. 60% of caregivers feel that they have responsibility in organizing and coordinating the members of the team. And I'm going to, again, dig into that a little deeper in a minute. Family caregivers spend an average of 11 to 30 hours caring per week. Think about that in the context of a full-time employed person who's now doing 11 to 30 hours over and above that, caring for somebody. We also know that sometimes they're doing 1 to 3 hours a week, and we also know that there are caregivers who provide 24/7, 365 care and can't even count the amount of care hours that they're caring. So now I'm going to dig into the stuff that's a little more specific to the healthcare world. So 51 to 54% of caregivers find transitioning between healthcare facility and home to be difficult. And we are also going to look at the other types of transitions and how geography affects that feeling of transition. But we know, we've heard since we were involved in the patient engagement work that healthcare transitions are one of the main challenges that both patients and caregivers feel. This one's really interesting because we look at where did they go for support, and only 28% of them turn to healthcare providers for support. And 58% and 44% respectively turn to the internet or turn to friends and family first. And so we really think we need to think about how do we support caregivers more proactively in the healthcare system. Also of interest is 9% approach disease-based charities for support, so that's pretty low on the list. And we also heard when we talked about sources of support that almost everyone wants one central place to go to for support, and we'll talk a little bit about how that's sort of coming together in the province of Ontario as we speak. So caregiver support, to dig a little bit deeper, 53% have got information on how to support the patient, but only 43% of caregivers get information about how to support themselves emotionally. So again, when we talked about, when you ask a caregiver what the impacts are, we heard a lot about financial impacts of caregiving. They're not small. We know that people are paying a lot of money out of pocket for caregiving responsibilities, and in fact, 22% would say that they've had financial hardship due to caregiving. We know that 1% of people have lost their jobs or left their jobs due to caregiving, and although 1% doesn't sound like a lot, we're talking about 30,000 Ontarians. So that is a notable number of people who are leaving the workforce because of caregiving. So again, when you ask a caregiver how are they doing, you'll generally get a very high level, oh, I'm fine. But when we looked at the data, we know that actually they are struggling in a big way. They're tired, frustrated, anxious, depressed, resentful, and many are even seeking their own support for mental health support. But we also know that they are getting sick themselves, and we hear lots of anecdotal stories about people who are caring for someone and the caregiver themselves gets sick and sometimes even passes before the person they're caring for. So we know that the implications are big. We are really happy to see that 60% of caregivers see themselves as part of the healthcare team. And so that's how they feel about it, but that's not also true for how others see them. And so that's where we talk a lot about that awareness component and really being clear that they need to be seen as part of the healthcare team. And I think when we think about OHTs and the requirement to think about how to support caregivers, that's where the integration into the healthcare team can be done effectively. And you're going to see some examples of that when I turn it over to Harpreet in a moment. So I'm now going to dig into some regional insights. We felt in light of the OHT activity, and because we had just completed our second annual Spotlight on Ontario Caregiver data, we were able to combine the data and provide a deeper look into some regional differences of caregivers. So this data looks at 1,547 respondents, and we divided them into a number of groups, which I'll talk about in a minute. I just want to pause here for a second and just highlight that this is our second year doing the survey, but we are partnering with the Ontario Caregiver Organization this year to do this survey, and we'll be handing it off to them in full next year to do and carry forward. And our partnership with the Ontario Caregiver Organization has been very strong, and we're going to talk a little bit more about what you can expect from them going forward as well. We divided the groups into regional groupings. We needed to have a minimum of 100 per group. So we had to combine some of the old LIN jurisdictions or the LIN jurisdictions to combine regional insights, but we still felt it was worth doing. And we each of these groups has a minimum of 111 respondents in it and up to 250. We used those geographies because it was easy to find the postal codes and be able to draw the regional insights that way, but the data can be cut in many different ways as we go forward as well. So I'm going to just highlight a couple of things, a couple of regional differences. I'm going to go through and explain to you what we did. We didn't take the entire data set and do it, divide it up regionally because some of it wasn't relevant for OHTs, but more importantly, that was an enormous amount of work and a very expensive endeavor. So we picked some key themes that we think are relevant in the context of OHT planning and have divided them up by region. And so these are the themes that we explored in that, as I said, combined data set that we have over the 2 years. So traveling distance, language barriers, the caregiver responsibilities, managing those transitions of care. So I'll talk a little bit about those transitions of care in a minute, the barriers to care and how that might differ by region, and access to support. So the idea that who are they going to for support, and what they want in terms of support. And as I said, overwhelmingly, one point of access for support came through loud and clear, no matter the geography. So I'm going to do a deep dive on two topics of those themes that I just mentioned, and show you some of the regional differences in these two areas. So organizing the healthcare team, as we said earlier, this is one of the major responsibilities that caregivers felt, that they're trying to coordinate between healthcare professionals, both in the same organization and across organizations, and people feel a lot of responsibility for this, and you'll often hear people talking about carrying their binders full of information. from one provider to the next. Obviously, this speaks to the accessibility of health records for patients and caregivers, but this is definitely a common theme. It's probably one of the top 3 things we hear caregivers talk about a lot. So 41% feel they have primary responsibility, and an additional 15% say they share that responsibility. The 2 regions where we see this being the most difficult, so 61% in Central region and 62% in Central East, Southeast, North Simcoe, and Muskoka. Interestingly, in Hamilton, Haldimand, Brant, this task was easier when we looked at those geographic differences. The other piece is the transitions of care. As I said, this is another very common discussion we have with caregivers. We've been hearing about it since our work in patient engagement. The transitions of care are the points where things fall through the cracks and where caregivers feel an enormous amount of responsibility and making sure that that doesn't happen or doing their best to do so. So 66% of caregivers have dealt with a transition over the past 12 months, and you can look at the list there in terms of what's the most frequent. So primary care to specialist is the most frequent. Between specialists is 18%, and then between hospital and home with or without home care is actually 29%, divided between those two at 16 and 13%. Those are the kinds of transitions that we're talking about. And we did ask people in the regions how many providers they're sharing information between and coordinating information between. And again, we saw that a couple of regions, Central West Mississauga, Halton, Waterloo regions, are least likely to have multiple providers. So we see that there, again, are differences between the experiences in regions depending on how many providers they have and how many transitions they're experiencing. So I'm going to just give you 2 examples of geography. We have a full report that goes into each of those geographies that I talked about and that we can share with you, and we'll give you how you can get that information, and we'll provide that in just a couple of slides ahead. So I want to just show you how we've divided up the data and what insights you might be able to draw when you're looking through the report that looks at the differences by geography. So I'm going to start with Erie, St. Clair, and Southwest. In this region, caregivers spend less time traveling for caregiving. They are most likely caring for someone who speaks English. So you can imagine that there are a couple of regions where caregivers are more likely to be caring for someone who is not speaking English as a first language, and that adds to the caregiving complexity in terms of interpreting and translating health information. They are, as I said, we did hear loud and clear that a central way of getting information about supports and government funding and other financial supports through one central location came across loud and clear, but this is, in this region, they are more likely to want that central location for finding information. So the second group I'm going to look at is Central. Just to, again, show you how the regional differences could help inform the work of your OHT. And we, again, picked the topics that we thought would be of interest and could be insightful and help inform your work. So in the Central region, people spend a lot more traveling for work, and they are more likely to be caring for someone that doesn't speak English. They find the tasks more difficult, which may also be attributed to more time traveling, and again, the added complexity of English as a second language. And they also are a group, an area that is looking for one point of access for information and supports, both emotional supports, what other supports caregivers can expect, and financial supports as well. So we wanted to share this with you because we feel that there are a number of ways that you can look at this data. The report shows by each region if your region is more or less likely than the average to be dealing with difficult transitions or want more information about financial support, or that financial support finances are a bigger barrier to care, for example. So you can compare how your region is different from others and against the median. And there are some definite distinct differences, as I've highlighted already, that I think could be very important to your OHTs as you're planning to involve caregivers and find ways of supporting them more effectively. If you would like to receive a copy of that report, we've got our email address on there, info@changefoundation.com. You can send us an email and we will send you a PDF of the report for you to review. It will be the same report submitted to everyone. We don't have geographic only reports, so you'll be able to see the differences in all the different regions and draw your conclusions and insights from that. I'm going to pause at this stage and just ask if there are any questions. Okay, I'm going to look through the screen here on the chat and hope that someone can help me just Methodology. Okay. So Kathy, I'm going to turn over to you to answer some of the questions while I catch up on reading the chat.
Sure. So there's a number of questions about, is this self-report and how did we identify people and so on. So what we did was, before we actually had our own survey, we had looked at the Statistics Canada special survey on caregiving, which was done some years ago and is being repeated, I believe, this year. And so we took their methodology and their definitions and replicated them as best we could in our own survey. We're happy to provide that survey if you're interested in the sorts of questions that we asked. In terms of how did we seek out respondents, it was a telephone survey, so there are definitely, we understand the limits of that. There are certain things that have to happen in order for you to participate. In terms of whether they were actively having a form of professional or unregulated care, I'm not exactly sure what that means, but what we were looking for were people who were engaged currently in caregiving or had done so in the previous year. It is self-report. Obviously, we're asking people questions about their own experience. We're not validating that through any other methodology. There's a couple of comments about the term care partner, and yes, we're aware of that becoming, I think, a more prevalent terminology, in large part due to Julie Drury, I think, here in Ontario, who has been a big advocate of the change in nomenclature, and we're certainly paying attention to all of that, and also looking at what happens elsewhere if the terminology hasn't changed. How do we deal with that? And there was also, I think, a question about travel distances. And yes, you'd think perhaps that people who are in more spread out areas, less dense population areas, would have less time to travel, but not necessarily so, because we hear directly from caregivers that they don't go. So if somebody's got to leave the community and travel for care, it's not always possible for families to go with. So it doesn't necessarily happen. And I am from Toronto, and I'm very aware of how much time it takes me to get around this city. I'm not going to say anything about the TTC. So, sometimes public transit takes longer. Okay, that was just a low remark. And then I think, have we covered them all? Okay. I think we've got most of them for now. So let's open it up, give you another second. Is there anything else you'd like to talk about? Lots of interesting ideas about the impact on travel in terms of public transit, weather, et cetera. These are all things that people as caregivers deal with every day when they're trying to get somewhere to an appointment with a family member. So keep them coming, and then I think at this point we will turn it over to Harpreet. She's going to take you through what the teams that we've talked about previously are for changing care teams, but also staff at the Change Foundation, what we have developed over the last 3 years, all been at the request of the teams in terms of what they felt they needed to continue doing this collaborative work, and all co-designed with caregivers. So I'll turn it over to Harpreet.
Thank you, Kathy, and thank you everyone for joining us today. As you may recall, Kathy talked about the care themes that came out of our engagement exercises, and what I'm going to do is walk through each of the I'm going to walk through the acronym and share with you some of the co-designed tools and resources that were developed as the project teams did a deeper dive in what each of these meant in their respective communities. So, for example, the first challenge that was identified by many of the project teams was navigation. And often they found when in the system, when we're talking about navigation, broadly when caregivers and patients are talking about communication, this falls under that bucket. And we generally think of navigation to mean movement between unconnected organizations or providers. And to address this challenge of navigation, two of the teams came up with two different solutions that I'm going to spend a little bit of time talking about. The first solution was a care binder, and the intention of the care binder was really to improve communication among health member teams, but also support patients and caregivers in managing their information. And every page of the co-designed binder, the binder was co-designed by both providers, patients, and caregivers. Interestingly, the binder is technically owned by the patient, and it also includes a discharge list. The tool ensures that caregivers participate in the discharge planning process by prompting both providers and caregivers to have a conversation to ensure that caregivers are well prepared for discharge, because we know they're often responsible for the ones managing care. A couple of interesting things have happened since the implementation of this binder that I want to take a moment sharing with you, because I think it's really important and relevant to the work that you will be doing in the OHTs. When the binder was first suggested, everyone in the system assumed we were talking about an electronic medical health record. And the truth of the matter was, the caregivers and the patients were really clear, no, they wanted a binder. And then we went back and asked them if they wanted a personal health record on their phones. And they were really persistent that they wanted a binder. So enter binder. And what became obvious as we started to implement the binder and the project team started to implement the binder was the patients now had something that they could hold on to, but also ask providers to ensure that the binder contained the necessary information. So when their caregivers weren't able to be there for appointments, they could share that information. So you started to see a shift of the accountability. Second, the nurses and the other providers who were supporting discharge realized that one of the biggest missing pieces was that a lot of patients and caregivers were leaving without a follow-up appointment. And they took it upon themselves to ensure that no patient would be leaving without a follow-up appointment, and ensuring that that process got embedded in their system for all patients. So you can see that there's now been, not just, it's no longer about communication, it's also about discharge. The binder is also now proactively being used by patients and caregivers between organizations, and they're taking it into the community, they're taking it to their primary care providers. And a year later, the binder is still being used, it's been adapted. And I think one of the reasons I spent a little bit of time talking about this example in specific detail was because I think it's really important to recognize the impact of co-designed solutions, and quite often there are impacts that go beyond the initial defined problem that you're trying to address. The second solution is a microsite created by one of the project teams, and when they did their engagement in the community, they found that one of the biggest challenges for patients, caregivers, and providers was not really knowing what resources were available within their respective community. They recognized that the Southwest Lynn was a large geography and had many services, but quite often those services didn't really meet the needs of people in their rural communities. So during the co-design session, what they wanted to do was they wanted to improve the Helpline website, and what they did was create a user-friendly site for their respective communities, and they had customized content to educate and create awareness of the programs and services that are available for caregivers and healthcare providers. Interestingly enough, they also decided that they wanted two separate sites, one for caregivers that really focused on their needs, but also a complementary site for providers. And what the providers decided to do was ensure that they had printable pages that they could direct caregivers to when they had specific questions. The next topic that came up was one of health literacy, again, under the broad theme of communications. And when we think of health literacy, we often think of big issues such as, funding and how that works and how the health system works. But what we found, and what the project teams found, was when you go into the community, sometimes health literacy needs to start with little steps. And all three of our project teams actually respectively found that one of the things that kept coming up through their co-designing process was just understanding what the role of each healthcare provider was within the circle of care. They wanted simple descriptions of what clinicians did along with their names and information that could help them recognize when they came into the room. So through their respective co-design processes, three of the project teams came up with role descriptions, and one of the teams included the role description within their respective binders. Another one created, as you can see, Meet Your Stroke team, prototyped a wall with the roles of each of the providers being outside the unit. And again, it was important to ensure that the solution that was designed was something that met everybody's needs. Another example from the communications perspective was related to meeting the needs of individuals when they came into organizations. So one of the project teams recognized that coming in for day surgery is very different from coming into their long-term care facility, and really just providing a simple video that tells clients that are coming into long-term care what to expect when you arrive at their facility. This really simple, plain language solution helps manage some of the anxiety for individuals, but also help them navigate the transition from home into long-term care. Similarly, one of our other project teams, Embracing Cornwall, launched a co-designed website where the content was created and co-designed by caregivers and providers. And the focus really here was the mental health and addictions population. The content in the website aims very specifically to support the needs of that community in that region and includes Francophone and Indigenous populations. So again, what you're seeing is very, very specific co-design supports for the needs of the community in a specific unit or a specific process or a specific organization. The second theme that was identified was the theme of assessment. And once the projects began their local discovery engagements, what we learned was that caregivers didn't necessarily want a formal assessment. What they were looking for was more specifically just people asking them how they were doing. So to this end, our project teams developed, one of the project teams developed the Time to Talk toolkit, as well as the Ask a Caregiver ID, and I'm just going to talk about each of these for a second. The Time to Talk toolkit is a self-recognition and support resource that helps both caregivers and providers understand the role of the caregiver, but also start a conversation. And it helps caregivers ask providers relevant questions, and at the same time provide some relevant prompts for providers to engage caregivers when they see them accompanying patients to their offices or to appointments. The Ask a Caregiver ID was a provincial initiative. Again, across the province, the Change Foundation had heard one of the challenges that caregivers faced was really the identification and recognition of their role. So as a provincial perspective, we had a working group come up with the Ask a Caregiver ID, and it provides some simple questions that you can ask a caregiver about how they're doing, and it's really based on the relationship. And this really was driven by the fact that caregivers didn't necessarily want an assessment. They just wanted someone to ask them how they were doing. All of the healthcare providers on the project teams had also talked about the importance of being able to share information amongst their team members, and that was really important to caregivers as well. And one of the opportunities was really to address the EMRs in this way. And one of our project teams co-designed an adaptation to their EMR that would allow them to include and document pertinent information, so they weren't having to repeat it consistently to all of the providers within an organization. And from a technology and privacy perspective, that solution was really was possible. The third theme was recognition and the role of caregivers, as you may recall. And for recognition, it starts with really the organizations identifying the importance of this. So one of the project partners recognized the importance of recognizing caregivers publicly in their role, So it wasn't just about their clients and their client bill of rights, but they created a commitment to caregivers. The commitment was co-designed with caregivers and providers, and this commitment is in the process of being formally adopted across their organization, and it will be publicly posted as sort of a first step of the organization's commitment to caregivers. A second cross-cutting project that we had worked on is the caregiver identification, and this is a visible way to demonstrate the commitment to caregivers. The caregiver ID is a card with a logo that helps identify caregivers, and this has been adopted in different ways across different organizations. One of our teams has actually integrated it with their family presence policy in the form of a pass card that gives access to individuals after hours when they're coming to visit loved ones. We have another team that has used it in the terms of a generic badge that is given to caregivers when they come to a unit, and when they come to the unit, they're required to return the badge when they leave. And a part of the reason they're asked to do that is because it serves as a prompt to nurses to help have a conversation with caregivers as to how they're doing. Finally, another way this has been used is, again, another generic way of using the badge. And one of my favorite stories is that the caregiver from one of the organizations that is using this identification actually wore it out to an appointment that they had with another provider who wasn't aware of this, and it really, the provider looked at the caregiver ID and asked the caregiver what it meant, and it enabled them to start a conversation about the implications of being a caregiver and the impact that it may have had on the person's health. And then finally, last but not least, we have the education theme. And across all of the projects, it was recognized through their own respective engagements, but also ours, that caregivers, providers, and patients alike recognized the need for education, formal and informal. So various different approaches to this were co-designed, and one of those approaches was a conversation from one caregiver to another caregiver. And this is one of a series of peer-to-peer supports, but it provides a really concrete example of how caregivers who shared similar experiences were able to share their lessons to allow other caregivers to learn from those lessons and actively engage with someone who has a similar lived experience. One of our provincial initiatives, again, after hearing that provider education was a need across all of the 4 projects, is the Caregivers and Partner Learning Suite. And this suite's really intended to help providers consider the role of caregivers and help them engage with caregivers in a meaningful way. It's currently being implemented across the 4 projects, and it's also publicly available. So an example of something a little bit more formal that has it requires a little bit more corporate coordination across the respective organizations. I'm going to spend a little bit of time talking about some additional resources, but what I would say is now that you have seen some of the examples of co-designed solutions, when you're thinking about change, whether it's system change and culture change, it's important to recognize that while any one of these solutions may not be the be-all, end-all solution, but when you start to add up all of these smaller solutions, what we've seen is, and what I think the changing care teams will tell you, is true changes in systems and cultures across their respective organizations. And all of these tools are available across our website. And I think many of these are relevant when you're thinking about some of the challenges that you are looking to address with your OHT work. I'm going to talk about a few additional resources that we have available. We know that a lot of the OHTs are thinking about collaborative governance models, and as Kathy mentioned, that a lot of the work that's been done through Changing Care is collaborative. And what we've shared publicly now and is available on our website is really an MOU or a partnership agreement to help provide some language. And it also allows you to consider the relative maturity of the relationships that you're now going to be undertaking. Another resource we have available on our website is the survey that was co-designed and developed by our project teams. We also engaged some experts. I know Sean Tracy is online listening. Thank you for the compliment about my hair. I really appreciate it. This survey is really unique because what it does is it provides you with 2 versions of the survey that provides complementary data for both providers, but also caregivers. And the questions align with each other. So pre and post intervention, you have a really great baseline for where providers are at and where caregivers are at, and then post intervention, the same type of data. So you can see how the movement's happening with both relevant groups. We also have our patient compensation tool, and this allows teams to think through the issue of paying patients and caregivers as they sit on their governance project teams, as they sit on their implementation teams in their various organizations. While we don't take a position on this, I think it's a really important exercise to consider as you think about how you will be engaging patients and caregivers in the OH teams. One of the exciting things about Changing Care is we've tried to share our knowledge as we go along, and we've developed learning reports along each of the phases of these processes, and we have 2 of them available, and one of them is on co-design and the other one is on engagement. And what's great about these is they're really practical tips on how to do co-design and engagement, and really based on the learnings of the project teams, and we provide some examples so you can see on the ground what some of the challenges are and what works and what doesn't work. We also have our caregiver wish list, and the wish list really demonstrates the advantage of engaging patients and family caregivers and health teams, and it also identifies some of the small things that caregivers can do to improve the experience of both patients and caregivers. And again, this is available online. And as mentioned, that you can access all of our content on our website. We have an online toolkit that actually gives you access to all of the tools and resources that we've mentioned. Most of the tools and documents that have been created are open access, so they allow you to access them, but also modify them and adapt them for your own context. Thank you. Questions?
So it's Kathy again. I will, because Harpreet's not had the ability to read through all of your comments while she was presenting, and I have. So I'll try and address what I've seen so far, and please keep posting if there's other things we haven't considered. A number of you have asked about the content being shared. So yes, we are sharing the slides. We will share a recording. All of the tools that Harpreet just mentioned are on our website. And the data that Krista talked about in terms of the regional cuts, we were happy to make available to any of you if you send us an email to the address that Krista mentioned earlier, and I can't remember what it was, but we'll get back to that. So yeah, we want to make, the reason we're doing this is we want to make sure that, you know, wherever we can help you and be supportive of your work, that you can use our material as best as you see fit. There was some commentary around community support services. So we are really clear on the importance of this sector in terms of people being able to live at home and live in their communities. So in fact, 2 of our Changing Care teams are co-led by community support organizations, and all 4 teams have got partnerships and relationships with organizations in their community. So yes, we are very clear on how important the contribution is there. There's been a bit of a chat about the notion of centralized versus local support, and it's a great issue to highlight for a number of reasons. There are a number of portals, websites, virtual communities that are centralized, often around either a disease or a condition or a type of service that is being provided, and they do certainly provide very good information for people who are looking for help. But that isn't for everybody. Some people don't want to try to navigate on their own. They would prefer to sit with somebody, preferably somebody they know and trust, like a primary care practitioner or perhaps a peer. And so trying to balance off what you can find on your own, online and elsewhere, and what you get through conversation was a big part of where we started with Changing Care, because we also realized that that is an expectation on healthcare providers that they may not have of themselves. So they don't necessarily think that it is, say, that the office's responsibility to go figure out what is locally available in their community and then be able to take the time to curate it and give it to a caregiver. So that service is required, and how do we make it simple? And so that's why Changing Care has spent a lot of time thinking about how to make that information accessible locally. And then the third thing is around the scale, is questions about scale and spread. Boy, that's a good lead into our next section and last section of this presentation. We, over time at the Foundation, have come to understand that we should not be engaging in something, getting a lot of enthusiasm and momentum going, funding it, and then disappearing without any plan for the work to continue in some way. So we worked very hard over the last couple of years with many others as well to push for the need for Ontario as a province to have a provincial level caregiver organization. There are a number across the country. They're not in every jurisdiction. BC, Alberta, Quebec, and Nova Scotia all have organizations. They're not all the same in terms of design, but they're all meeting a need. And so just before the last provincial election, the Wynne government announced a caregiver organization. It is now in place, and we will be talking about that in a few minutes in terms of where they're at and what you can expect. But before we get to that, we want to just talk a little bit about you guys. And if there's anything, now that you've had a bit of a sense of what we are doing here and what we have to offer, if there's anything else you think we could do, we could help with, if there's additional information that we can provide, if you're thinking about caregivers in your jurisdiction, if there are other needs that you think we've not covered, we've not met, we would be very interested in hearing about that. So again, we do have some plans for scaling and spreading the tools in terms of what we would do ourselves, but also what we will do with OCO, which we'll get into. And yes, there's a question about other similar tools in other provinces. As I said, other provinces do have caregiver organizations, and they do have resources on their websites that link you to other tools in that province. And we are happy to provide the web links to those organizations after this webinar is over. So if there's I'll give you 2 seconds. Good question. How will OT support caregivers who are having issues with language barriers? Obviously, I can't answer that, but it is probably a need that I'm sure OHTs are thinking about, and we can probably, again, come back to that if we have time at the end. We've got about another 30 minutes. So let's move on to talking a little bit about the Ontario Caregiver Organization so that you have a sense of what that is. One more question here. Do we know what proportion of OHT applicants have caregivers embedded at their planning tables? We do not know that, obviously. We're not involved in reviewing those applications, but we should love it if you guys would ask. Because to be frank, from what I've seen online, and this is social media discussion, so I'm not claiming that this is anything other than that, but there does seem to be a fair bit of commentary about some disappointment at the level of engagement of patients and caregivers at this stage. I can't say anything more than that. There's some commentary on it, and obviously our view would be that they should be there every step of the way. So let's move on to the OCO discussion.
So, as we've mentioned a couple of times, there is the Ontario Caregiver Organization, which is now in existence, and it is created to bring a lot of the caregiver work that's happening across the province together and be that central resource to be able to find supports and information in your local area. It is a disease agnostic organization, and as I mentioned earlier, we know that caregivers are looking for that central way to access, and we know that there's both provincial-wide supports, but also local resources that people want to access, and the Ontario Caregiver Organization is set up to help facilitate that. And they will be actually launching an Ontario Caregiver Helpline in just a few weeks, so October 1st, and looking at a public awareness campaign that will help raise the awareness of the issues of caregivers that we hear again and again. and help with that self-identification issue, which is often a barrier for people reaching out for support. So this helpline will have 27 resources, and you'll be able to talk to someone by live chat or phone and be able to be directed to resources in your local area. And the Ontario Caregiver organization, being as new as it is starting off tackling this, but is going to be working on being that voice and bringing forward the voice of caregivers in Ontario in the coming months as well. So there's lots of hope in terms of the focus that caregivers are getting in Ontario. The OHT is another opportunity for that, and we hope that OHTs will reach out to the caregiver organization to see what you can get involved with in your local level as well, especially if you have caregiver resources that they should be aware of. So you can find out more about the Ontario Caregiver organization on their website or follow them on Twitter. But we did want to do a shout out to one of our key partners who is really collaborating with us and helping to spread and scale some of the work that we've been doing over the last number of years. So that brings us to the end of our webinar. I just am going to scan the screen to see if there's any additional questions we want to address. And then we can talk just a little bit about how to get in touch. So Kathy, do you?
Sure, I will there's a couple of, there are more comments, but I think they're so germane to the conversation that we're having about the engagement, true engagement, whether there's tokenism, et cetera. Obviously I'm not going to make any editorial comments about that, but what I would say is do not bring people in after the fact. If you're going to do true engagement, caregivers and patients must be there every step of the way from the beginning, because if you don't do it well, it will blow up in your face. And I think our biggest fear is that if the engagement piece of this is not true co-design, solutions will get formulated and approved and potentially implemented, which will have very little to do with what caregivers actually need. So even though it is time consuming and it may slow down some of the planning, and I appreciate that there's this looming deadline, I think it's really important to get this piece right, because it will set a tone for the rest of the work that will be either very, very positive or not so much. So I will just leave that comment there. We are very available if anybody would like some help thinking through engagement plans. We actually have, again, on our website, there are a number of documents that might help you think about how to do engagement well. We have top 10 lessons that we've learned through trial and error with engagement work that we've done in the past. So as I say, we're very available and happy to help you if you think we can contribute something in that way.
Yeah, so we're encouraging to reach out to us for more information on engagement, for that report on regional insights if you would like a copy of it. If you want to learn more about co-design, or you want to be able to adapt some of the resources you saw today, all of those are available on our website, but don't hesitate to reach out. And if there are other ways that you think we can help as the OHTs evolve, information we can provide on caregivers or any other way, please reach out to info@changefoundation.com. And we're thrilled to have had so many people here today and representing such a great diversity of stakeholders in the healthcare system. It really is good to see so many people joining us today.